Welcome back to our last pilot presentation of the day for BigMedilytics event. This time it's on lung cancer. From Germany, we have Professor Dr. Maria-Esther Vidal of the Scientific Data Management Group at Leibniz University of Hannover and the Leibniz Information Center for Science and Technology. Joining her is Dr. Maria Torente, head of the International Medicine Program at the Hospital Universitario Puerta de Hierro from Spain. Team, the floor is yours.
Hello, everybody. I'm Maria Torente, and the name of the hospital was very well pronounced. Thank you very much. I'm going to start with the description of the lung cancer pilot from the clinical point of view. As you know, lung cancer is the most common cause of cancer death in Europe, so the costs are extremely high, and especially from the patient care from the moment of the diagnosis and throughout all the follow-up. With our pilot, what we wanted to stress is the improvements that could be made in the management of the patients since diagnosis, and as I said, throughout all the treatment follow-up and during the last period of life. Not only that, we wanted also to improve the patient's experience within the hospital and at the same time save costs to our healthcare systems. We have focused in readmissions and scheduled visits, toxicities and comorbidities, and what do they represent to these patients and to the healthcare pathway, and to reduce visits in the emergency room, as well as hospital length of stay at the hospital. We have selected 5 key performance indicators. Next slide, please, Maria-Esther. And where we selected first numbers where we could start pre-intervention or as a baseline with the length of hospital stay. People are at risk of developing lung cancer, which hadn't been assessed before, admissions at the emergency room, toxicities in patients with comorbidities, and finally the patient satisfaction. Throughout the lung cancer pilot, we have a clinical pathway, as you can see, and we have focused in the different interventions at different moments of this pathway. First, in order to identify the people at risk of developing lung cancer, this has made possible that studying the year prior to diagnosis, we have been able to detect the different appointments that the patients have made, not with oncology but with other services, and with these identifications, what we have made is a fast track for our lung cancer patients, so that diagnosis tests are ready whenever the consultation with oncology department comes to a date, and we have a suspect of lung cancer. Second intervention is with these in an asymptomatic phase of lung cancer, which is a bit like a screening method. What we do is to explore the services that have been visited by the patient the year prior to the diagnosis. In our case, we found that primary care, followed by emergency room, cardiology and pneumology were the services that were more visited by our patient. And this has made possible that we have prescription with medical interventions for these patients. So everything is much more, as I said, is established fast track, and we have been able to characterize patients before a diagnosis or in an asymptomatic phase. During intervention 3, right here, what we have done is this identification during the follow-up of the most visited services, apart from the medical oncology department. In our case, it was emergency room, the department that has been more frequently visited by our patients, and the pain being the most common symptom that as you know correlates with disease progression. So we have established, thanks to this KPI, pain assessment with an early referral of all of our patients to the pain unit at the hospital. Regarding intervention 4, what we did was study complex patients that visited emergency room and were readmitted in our medical services within 28 days from these readmissions. Now we are capable of identifying these patients and early process interconsultations to the departments that are due to be visited by these patients due to predictable and not predictable side effects. Finally, regarding the 5th intervention, we have studied the readmissions and in the emergency room and death of the patient within 28 days after being discharged. In this is 30% of our patients, which is a lot. And what we have done is promote early referral to palliative care, so that these patients, instead of coming to the emergency room and then staying here and be hospitalized and die at the hospital, they are attended at home by our palliative care team. And with this early referral, we are capable of a better care of these patients. Also, we have identified our profile of this kind of patients. It's a patient over 70 years old, advanced stage of the disease, more than 3 comorbidities, and who has received more than 3 lines of treatment, usually chemotherapy. This is the table with all the interventions. Now, Maria-Esther, if you want to proceed with the analytics part.
Okay, so well, many thanks, Maria, for giving this clear presentation of what we have achieved in terms of interventions. So, in order to explain what we have done from the technical point of view, so in order to support the analysis of all the clinical data that lead to the definition of these interventions, we have implemented a dashboard. And this dashboard actually integrates services that are able to analyze the different populations that have been collected from the hospital of Puerta del Hierro in Madrid. So with this analysis, we are able to profile, or the clinicians are able to profile the patients and satisfy the KPIs that Maria was mentioning before. Some examples of these services. So we were able to study the length of the stays at the hospital. We also were able to analyze the correlation between the comorbidities and the visits to the services. We were able also to analyze the treatments and the toxicities of these treatments and the services that these patients were presented. From the technical point of view, we have a knowledge graph. I'm going to explain also the knowledge graph. And this dashboard is also able to explore this knowledge graph. And we have a question answering system that receive questions in natural language processing. For example, which are the drugs that interacts with a particular drug. And based on this natural language processing, we are able to answer these questions to the clinicians. Some examples of these services that were helping the definition of these interventions are, in this case, what are the services that are visited by the patients previous to the diagnosis of lung cancer. And in this case, in the period between 4 and 15 months previous to the diagnosis, we have identified that, as Maria was saying, emergency visits to the emergency room was the most frequent one, and followed by primary care, cardiology, or pneumonology. When we also with this analysis, we were able to see the progression of how, if we were changing the months before or previous to the diagnosis, which were the services that were visited the most, or the profile of the patients that were readmitted to the hospital after 20 days or before 20 days, when they were hospitalized because they were in the first line of treatment, or which were the services that were requesting the majority of the test for these people who were also in this very bad condition during the first line of treatment. So this is at the level of the services, but how this was implemented. What we have implemented is this is the front end, the dashboard, but the dashboard actually is the front end of a huge data ecosystem that implements knowledge-driven approaches that are able to capture data and knowledge from different from different data ecosystems. In this case, we have data that is recorded in the clinical records. We also have data that is coming from the scientific databases, and we also have knowledge that is coming from the publications. Everything is processed and is integrated in a knowledge graph that, using ontologies, is describing the meaning of this data and is helping in the explainability of the services and the machine learning methods that are implemented on top of the knowledge graph in order to support all the services that were helping the clinicians to define the interventions. These data ecosystems that compose this huge knowledge-driven ecosystem were processing natural language, were applying natural language processing techniques in order to process the electronic health records, who were notes and structured notes that were written by the clinicians, and they were having all the information that was required to understand the comorbidities, the treatments, and all the services that the people were visiting. Also, we had extracted from the clinical records all the toxicities that the people were having, and from the scientific databases, the knowledge about interactions between drugs, or from the scientific publications, what was reported about these toxicities. So these are the techniques. They were focusing on extracting all this knowledge from the electronic health records, or from the scientific publications, or the integration in top of the knowledge graph, the transformation of all this data in order to have a knowledge graph that was validated using techniques of checking integrity constraints. At the end, we created this knowledge graph that is composed of more than 110 million triples, and that enable for the explanation not only of the data that is integrated, but also how this data was integrated. So in that way, we support transparency. We are able to explain when we have validated an error that the data was integrated following a certain pipeline. Also, we have implemented services that are able to support all these interventions that were defined, and services for knowing which are the line of treatments and the cancer stage and the correlations with the comorbidities, and the drug-drug interactions and how they affect the visit to the hospital and also the quality of life of our patients. These techniques, of course, are tuned to the lung cancer pilot, but they can apply to any other pilot as soon as we have the data. And also in terms of the natural language processing that were applied in the electronic health records, that we require to have, of course, a learning process in order to adjust these techniques to new electronic health records. Who are the partners of this consortium? As we were saying, the Hospital Puerta del Hierro in Madrid. They are the clinicians, the oncologists who are providing the data, who are implementing all the interventions. We have the Universidad Politécnica in Madrid, who is implementing all the natural language processing techniques over the electronic health records, the National Center of Scientific Research in Demokritos in Greece that implements all the techniques for natural language processing in publications. We are at the University of Hannover implementing the knowledge graph, and the dashboard that was implemented on top of the knowledge graph is done by ATC. So, well, with this, I'm closing my presentation, and thank you all of you for attending our talk, and we are ready for questions.